Thank you, organizers, for giving me this opportunity. So, what Dr. Akhil was discussing about the PD-L1 is just imperfect marker. We need something more. At the same time, is only immunotherapy one is enough? How to increase the effectiveness of the immunotherapy? And WCLC, the first abstract presented by Dr. Advait, was showing the Ivanizumab. And so now this is a new drug, Relatlimab. Also, this was used and approved in melanoma in the past. This is in the lung cancer. Nivolumab plus Relatlimab with platinum-doublet chemotherapy versus Nivolumab plus platinum-doublet chemotherapy as a first-line treatment for stage 4 or recurrent NSCLC result from randomized phase 2 trial. And this is Nicholas Girard, but there are a few Indian names you can see, and from the US. So this is the background. What is Relatlimab? This is a RELA. I will call it as a RELA. It's a human LAG3 blocking antibodies, lymphocyte antigen gene, lymphocyte activating gene 3 blocking antibody that restores the effector T cell function. So here we can see at the side the mechanism of action where it is shown that activated CD4 and T cells and CD8 cells having the receptors where RELA is blocking LAG3 and Nivo is blocking PD1, and that's why it is giving combination as a result. So this is the first randomized phase 2 study to evaluate LAG3 blocking antibody containing regime as a first line treatment in metastatic NSCLC. At the part 1, which was a safety analysis, the safety was demonstrated, and this is a part 2 where the effectiveness was demonstrated here. So this is eligibility criteria: first line, stage 4 recurrent, no prior systemic therapy, no EGFR, ROS, ALK, ECOG PS01 tumor, and they are certified on the basis of PD-L1, that is more than 1%, less than 1%, histology non-squamous, squamous, and 309, which is a significant number of patients were enrolled in it, and Nivo 360 milligram, and RELA as a 360 milligram, although it was little lower dose in melanoma trial, which was approved. Which is combined with platinum doublet chemotherapy, 4 cycles, which is compared with the Nivolumab with platinum doublet chemotherapy. So the primary endpoint was overall response rate, and the secondary was PFS and safety. So here, part 2, we can see Nivo-RELA versus Nivo. They both are quite comparable. So now this is a safety summary. Safety summary, you can see the all type of adverse events here, which are also quite comparable. There are a few comments on it. Serious adverse event, you can see grade 3 and grade 4, where 33, which is 21% in Nivo-RELA compared to 22% in Nivo arm. And that leads to, there are a few points they have mentioned, but only when you see neutropenic adverse events, that more than grade 3 treatment related neutropenic adverse events occurred in 6% Nivo-RELA as compared to 14% in Nivo. And that leading to death is neutropenic sepsis, febrile neutropenia, and pneumonitis and pneumonia were the causes. And so most common adverse event here this mentioned as anemia, nausea, neutropenia, thrombocytopenia, and fever and fatigue. So here the randomized, so all randomized patient, this is all patient comparison, and this Nivo-RELA versus Nivo, 6.7 versus 6. Not, the gap is not that big, and the HR is 0.88, and the difference in the response rate is 51.3 versus 43.7. But when they analyze in a subgroup population, then they can see, so although that PD-L1 more than 1%, we were discussing about whether it is a correct marker or not, but this is here what they have seen is more than or equal to 1% PD-L1. The Nivo-RELA is 9.8 median PFS versus 6.1 as a Nivo arm, and which is the forest plot suggests that it is a significant. HR is 0.63, and overall response rate 52.2, 53.2 versus 40.8. So when you compare the non-squamous versus squamous, 8.3 versus 6 is median PFS, although this HR is just 0.686, and 47.7 Nivo-RELA versus 38.5 overall response rate in a Nivo arm. So here is the subset, which is a PD-L1 expression more than 1% and non-squamous PFS and overall response rate. Here we can see median PFS in Nivo-RELA arm is 11.6 versus Nivo arm is 6.9 with HR 0.55, which is quite significant. And the difference of overall response rate is 58% versus 39.6%. So specifically PD-L1 more than or equal to 1% and non-squamous data, the significant difference is seen. We divide it into 1 to 49% and more than 50% as per the PD-L1 expression and non-squamous. The Nivo-Rela arm is 9.8 versus Nivo is 5.6. HR is very significant, 0.45. And we can clearly see the separation of curves, and the difference in overall response rate is 60.7 versus 30%, and which is significant. So specifically this subset, PD-L1 expression 1 to 49% and non-squamous, the highest benefit was found. When the PD-L1 expression is more than or equal to 50%, it is the difference of median PFS is 13.8 versus 7.1. HR is 0.6, significant difference 54.5 versus 46.4, but it's significant, but as compared to the subset that we have mentioned, it is little less. The summary of this is Nivolumab plus Relatlimab 30-60 milligram in metastatic NSCLC. This RELATIVITY-104 is the first proof of concept randomized phase 2 study in the metastatic NSCLC that demonstrated improved clinical benefit from addition of LAG3 inhibition to anti-PD-1 plus chemotherapy in PD-L1 more than or equal to stratified and pre-specified patient subgroup, which was further enriched with the non-squamous histology. The safety profile with Nivo-Rela plus chemotherapy was consistent with the known profile of individual component of combination, and which showed no increase in adverse event versus Nivo arm. The RELATIVITY-1093 that is coming up, it is open label randomized phase 3 study evaluating Nivo-Rela plus chemo standard of care, just compare with the standard of care pembrolizumab plus chemo as a first line treatment for patient with metastatic NSCLC having PD-L1 expression 1 to 49% and non-squamous histology. Additional phase 3 study for patient with metastatic NSCLC having PD-L1 more than 50% and non-squamous histology is currently under development. Thank you.